Hello everyone, I am Dr. Rushi Patel, second year resident doctor of radiology department from Shivsha Medical College. I am presenting a case in a case of the week series. Patient history. 64-year-old male patient Arvind C referred to radiology department for MRI brain with head angiography investigation with a complaint of convulsion with weakness of all limbs associated with uprolling of eyeball, tongue white, frothing from mouth, with history of slurring of speech since 4 to 5 days, with history of visual disturbance since 2 to 3 days. Patient has chronic history of alcohol consumption and is on currently withdrawal treatment. Patient has past history of previous CVA 10 years ago. Patient has history of hypertension since 10 years on regular medication. Patient don't have history of diabetes mellitus and TB. Patient was unconscious at the time of presentation. Important signs and symptoms at the time of presentation: seizure, headache, and visual disturbance. The following MRI sequences T1, T2, and flare shows numerous serpiginous fluids in right parieto-occipital region. Following images are of T2 coronal section and in T2 sagittal section shows numerous serpiginous fluids in relation with posterior cerebral artery in right parieto-occipital region. Gradient echo MRI sequence shows areas of blooming in right parieto-occipital region. Following MR angiography sequence shows multiple vascular channels of various sizes with visualization of nidus formation and right parieto-occipital region. Most of the feeder vessels are from right posterior cerebral artery. However, few are arising from terminal branch of right middle cerebral artery. There is evidence of multiple dilated draining veins into superior sagittal sinus. Non-contrast CT image shows area of calcification in right parieto-occipital region. My final diagnosis is cerebral arteriovenous malformation in relation with right posterior cerebral artery. Discussion. Brain arteriovenous malformation are type of intracranial high flow vascular malformation composed of enlarged feeding arteries, a nidus of vessels closely associated with the brain parenchyma through which arteriovenous shunting occurs and draining veins. Clinical presentation. Cerebral arteriovenous malformations are the most common symptomatic vascular malformations. Possible presentation include incidental findings in asymptomatic patients, seizures, headache, ischemic events due to vascular steal from normal brain, and hemorrhage. Location: supratentorial, infratentorial. In supratentorial, there is superficial and deep. Incidence: solitary arteriovenous malformation 98%, multiple arteriovenous malformation 2%. Associated abnormalities: flow-related angiopathy secondary to endothelial hyperplasia, flow-related aneurysm, intranidal located in the nidus, intrapedicular located in the feeding vessel, remote aneurysm hemodynamically unrelated to malformation. Classification and grading. Brain arteriovenous malformations can be divided into two types: compact nidus, diffuse nidus. In compact nidus, abnormal vessels without any interposed normal brain tissue, more common than diffuse nidus type. In diffuse nidus, no well-formed nidus is present with functional neuronal tissue interspersed amongst the anomalous vessels. When early venous drainage is absent, there is considered cerebral proliferative angiopathy. Differential diagnosis. Imaging differential considerations include other cerebral vascular malformations like cerebral proliferative angiopathy, craniofacial arteriovenous metameric syndrome, dural arteriovenous fistula, developmental venous anomaly, vascular tumor, and glioblastoma. Treatment and prognosis. In general, the three options available are: 1. Microsurgical resection, 2nd. Endovascular occlusion, and 3rd. Radiosurgery.